All right, we're going to get started. I have no disclosures relevant to this talk. The objectives of this talk are to go over the goals of treatment, the tools that we use to monitor disease activity, a treat to target approach and what that means, and the importance of endoscopic healing. So, in the treatment approach to inflammatory bowel disease, the first step is to assess the activity of the disease in terms of how severe the disease is, and also to see if there is any risk factors that indicate severe disease. For example, the extent of colon involvement in ulcerative colitis is an indicator of severity, or in Crohn's disease, people who have fistulas have a severe disease phenotype, which carries a higher risk of surgery. And using biomarkers, it's a complex term, but it's essentially blood tests and stool tests, and correlating them with endoscopy to make sure that you can use them as markers for monitoring disease activity down the road instead of doing colonoscopy all the time to find out how active the disease is. And then we have a discussion about risks and benefits of individual treatment options, and then the process of starting treatment and disease monitoring, which is what we're going to talk about, starts. And subsequently, there's assessing for response and remission, and in the long term, assessing for endoscopic healing. So let's take the case of Haley, who's a 24-year-old PhD student with ulcerative colitis. She was diagnosed when she was in high school. She was tried on oral medications with some initial success, but subsequently she was having flares. She was requiring courses of steroids, and she was tried on an oral immunosuppressive medicine, what is azathioprine, commonly known as Imuran. But then she had a side effect with it, which is pancreatitis, which is inflammation of the pancreas. And then, she had to stop taking that treatment. Her last colonoscopy was at the time of the initial diagnosis. Now she is experiencing symptoms of a flare, essentially, all the symptoms that you'd expect from a flare of ulcerative colitis, which is frequent bowel movements, blood in her stool, urgency, or the need to rush to the restroom when she's having abdominal cramping, and blood in her stool. She has been missing classes because of this, because of her symptoms, and she, because of the active symptoms, she's not been able to participate in activities with her friends, and she's worried that she may not be able to attend her sister's wedding. So her goals are to actually, get well better so that she can go and attend her sister's wedding. On endoscopy, she had moderately active colonic inflammation, which is also confirmed by biopsies. She had both stool tests for inflammation, which is what the fecal calprotectin is, and as you can see, it's significantly elevated. Blood tests for inflammation, which is what CRP is, and again, you see that it was significantly high. She was not anemic, thankfully, but she had low iron reserves. Her stool tests for infection were negative, and she was started on steroid treatment as well as biologic treatment because of the severity of her disease, her past history that she has required frequent courses of steroids. She tried an oral immunosuppressant, but then she could not. She had a side effect from that. So at the time of starting treatment, there has to be a discussion about what to expect, which is a discussion about expectations from the medication itself. And what that means is how quickly you can expect a response to treatment in terms of improvement in symptoms. When can you expect near complete resolution of symptoms, which is what is called clinical remission. And then long-term goals, including when can you expect your colonoscopy to show complete healing of the lining or near complete healing of the lining. And the goals, to establish at the time of treatment include, obviously, we want everybody to feel better on treatment. So that means, making sure that the symptoms go away, but also important social goals. For example, she wants to attend her sister's wedding, and we have a timeline to work on to make sure that she's able to do that, and not to miss class and have fun with her friends like everybody else, so that there's minimal or no impact on her quality of life. And then all of these drugs have potential side effects. So we have to make a plan about monitoring for safety, and that includes periodic communication to make sure that the symptoms are actually getting better. Tests, which include blood tests and stool tests, to make sure that they are responding to treatment as we expect, and if they are not responding, kind of figure out why and make adjustments as needed. A telemedicine visit, which nowadays is now very popular, to make sure that things are on track in about 4 to 6 weeks, and an in-person visit in about 3 months, and long-term plan for colonoscopy in about 6 months to a year, to make sure that everything as far as inflammation on colonoscopy and hopefully with biopsies as well has improved. So the goals of treatment, though the individual will have certain goals of treatment, and the doctor is having something else in mind, and these overlap. Don't get me wrong, these overlap. We want everybody to feel better, but we should try to achieve more than just feeling better, right? And the reason for that is we want to try and change the course of disease, prevent structural bowel damage and disability, and improve health-related quality of life. And for that, we are going to talk about symptoms and how these impact the way trials are assessed, and what that means when you look at, say, for example, the doctor tells you that clinical response was this much percentage with this drug, right? So IBD is associated with a long list of symptoms, the commonest being diarrhea, urgency, abdominal pain, and blood and stool. And these are mentioned in the clinical trials as what's called patient-reported outcomes. And by targets in the clinical trials, they have all these definitions for what is called clinical response, what is clinical remission, what is endoscopic remission, meaning that at colonoscopy what is actually called remission. And then there's some aspirational goals now. These are not actual targets right now, but hopefully in the future we'll have these as targets so that we can change the course of the disease and impact long-term outcomes. So in the clinical trials, this is what is used as a definition for response and remission. So in Crohn's disease, they're talking about 50% improvement in abdominal pain and stool frequency. And in ulcerative colitis, they're talking about a 50% improvement in the frequency of bowel movements and the reduction of decrease in the amount of blood in stool. And by clinical remission, what they mean is minimal or no symptoms, specifically referring to these symptoms. So, as you can see, there's some discrepancy between the long list of symptoms that patients report and what the clinical trials are looking at. So, you should understand that difference, when your doctor or, whoever is discussing treatment with you talks about, this is the rate of clinical response and this is the rate of clinical remission. But clinical remission by itself is not adequate, and we know that from data that we have from a long list of trials going back more than 20-30 years. The ultimate goal of treatment should be to make sure that we prevent progression of disease, prevent structural damage to the bowel, and prevent disability. And treating symptoms, however, is not adequate enough to achieve these goals. And the reason being that often when somebody has had symptoms for a long time, they are either not recognized as symptoms, or they don't report them as symptoms because they've gotten used to having these kind of symptoms for a long time. And there's also frequent discordance between symptoms and objective assessments of inflammation. For example, in one of the Crohn's trials, 50% of patients who were in clinical remission had severe inflammation at colonoscopy. And up to a third of patients with symptoms did not actually have ulcers, which is the definition of active disease in Crohn's disease. Up to a fifth of patients in ulcerative colitis, even if they're in clinical remission, can have active disease at colonoscopy. And sometimes there's a discrepancy between the colonoscopy and symptoms in terms of even if the bowel movement frequency is still there, and there is a colonoscopy done, for example, for ulcerative colitis. everything might look healed up, and there may be other causes for having bowel movement frequency at that point, which I think there is a talk subsequently by Dr. Saha who's going to talk about why that might be and what other things to look at. It's also important to recognize that mucosal inflammation is associated with long-term poor disease outcomes. These include complications, disease flares, and the need for surgery. So, treat to target is an approach that is borrowed from other diseases like diabetes, hypertension, rheumatoid arthritis. And the idea is that these targets are signals of low disease activity or indicate remission. And these are applicable in conditions where symptom management alone is not adequate. For example, common example is high blood pressure, right? You can have high blood pressure, not have any symptoms, and over a period of time, if it's uncontrolled, people have complications. And that's kind of the same scenario with inflammatory bowel disease. So this is a consensus document among international experts about what the target should be and what the timeline for target should be in the treatment of active IBD. And if you start on the left side of the slide, there is where there is active inflammatory bowel disease. You start treatment based on the risk that, like we discussed earlier. And the immediate goal, obviously, is to make the individual feel better. And that's what symptomatic response is. And then the intermediate targets are not only to make sure that the symptoms go away completely, but also other things including normalization of blood tests for inflammation. And in the intermediate to long term, normalization of stool tests for inflammation. And in children particularly, to make sure that they achieve their normal growth pattern. And long term, to achieve endoscopic healing and improve quality of life and prevent disability. So what are we talking about when we say short term, intermediate term, and long term? Short term, we are talking about weeks to months. Intermediate term, between months to a year, and then beyond 1 year, the idea is to achieve disease modification and thereby change the course of the disease. And just to kind of simplify this, we're talking about immediate goals, which is clinical response with significant improvement in symptoms. Intermediate, within 3 to 6 months to achieve clinical remission, and not only just symptom improvement, but also normalization of CRP, which is a blood test for inflammation, and reduction in the stool test for inflammation to an ideal range, which is somewhere between 100 and 250. So this is the anticipated timeline of when you can expect response, remission, and normalization of blood tests and normalization of stool tests and endoscopic healing. I know this looks really complicated, so I'm going to just simplify that just so that it's easier. So steroids are the fastest acting medications. That's why they're commonly used when somebody is in a flare. Usually response is within 2 weeks. But you can expect significant improvement in these treatments within 2 to 10 weeks. And that's the range for the medications that we have right now. As far as remission, it takes anywhere between 1 to 4 months for these treatments. And same thing with normalization of the blood test, which is normal CRP and ESR. And again, normalization of stool tests takes a little bit longer. And we are talking about somewhere between 2 to 4 months for normalization of stool tests. Endoscopic healing, where the lining of the colon and the bowel looks healed up with no ulcers, takes longer. And often, it can take anywhere from 3 to 6 months, if not longer, up to a year, depending on, response for the individual. So going back to Haley, at 4 weeks, she was feeling better. Her bowel movement frequency had improved. The amount of blood in her stool had gotten better. The stool tests have gotten better, though they are not in the optimal range yet. Her blood test for inflammation has gotten better or normalized. So just a word about the stool test for inflammation, what's called stool calprotectin. It is a protein that is produced by inflammatory cells, and it is a good correlate for inflammation in the bowel. But it doesn't tell us what the inflammation is from. So if it is high, we assume that it is from the disease as long as we make sure there's no infection or some other cause for the test to be high. And reduction in the stool test correlates with important long-term outcomes. For example, at 12 weeks, a significant improvement in the stool test correlates with long-term healing, clinical remission, and endoscopic healing. And a level less than 150 correlates with endoscopic healing, though there is some overlap between levels at 100 to 250, where there may be some individuals with still active inflammation at a level even within that range. The other commonly used test is the blood test for inflammation, what's called C-reactive protein. It is not as accurate as the stool test for inflammation, and it's important to recognize that not everybody has an elevated or a high CRP level when they're experiencing a flare. So for this reason, when somebody is experiencing a flare, they should have a CRP checked. And if they have a high CRP, then that should be used as a goal to normalize as part of treatment. But if they don't have a normal CRP, even when they have active disease, we can't use the CRP as a marker for response. And normalization of the CRP does predict remission when it's achieved. So going back to Haley, at 3 months, she feels great. She's completed her steroid course. Usually, steroids are used short term, somewhere between 6 to 8 weeks of steroid course is usually recommended. She's had normalization of her bowel movement frequency. She no longer has blood in her stool. Her calprotectin, which is a stool test for inflammation, is in the ideal range. Her blood test is which is the CRP, is normal. So overall, she's doing well. So we agreed on a monitoring plan for a colonoscopy about 6 months down the road and a clinic visit at 1 year. So the long-term goals for treatment are endoscopic healing, which is assessed by either colonoscopy or sigmoidoscopy depending on the extent of disease. And in Crohn's disease, it is defined as absence of ulceration. And in ulcerative colitis, the colon lining should appear either normal or near normal. And other long-term goals include absence of disability and normalization of health-related quality of life. Endoscopic healing is important in IBD because it predicts a lot of favorable outcomes which are important. And these include long-term clinical remission, reducing the need for steroids, reducing the need for hospitalization, the need for surgery, as well as long-term improved quality of life. So Haley was able to do well, and at her colonoscopy, she had complete healing of her colon lining, as you can see in that picture. She met her important goals, including making it to her sister's wedding, not missing classes, and she was able to find a date online at the end of the year. Just a word about therapeutic drug monitoring, which basically means measuring the level of biologics to adjust treatment. And this is done when people are not responding as they're expected to, or if somebody is doing well and they start having symptoms. Say, for example, if they're on injection and when they're due for their injection in the weeks before or the days before, they start noticing increasing symptoms. And the idea is that by measuring the level, we can kind of either adjust the treatment if needed or switch treatment if that is appropriate. And in certain cases, particularly in individuals with severe disease, it is done proactively to make sure that they're able to achieve response and remission. And this is approved, or at least this is recommended by the American Gastroenterology Association as a way of making sure that we are able to meet our treatment goals. So in summary, treatment goals should be discussed at the time of initiating treatment. Symptoms may not always correlate with inflammation. Symptoms and inflammatory markers should therefore be monitored to ensure both response and remission. And treatment should be adjusted if needed based on monitoring. And endoscopic healing predicts long-term favorable outcomes. Thank you for your attention. So Becky is going to hand over the post-test questionnaire. If you could kindly fill those. Thank you. Please go ahead. Mural means wall. Transmural means the entire wall. Because Crohn's disease is full thickness bowel inflammation. And what the ideal goal is to heal the entire thickness of the wall where there is inflammation. So, endoscopic remission means that, say, when you do a colonoscopy, there is no ulcers or there are no ulcers in Crohn's disease. So, that's what's considered healing as opposed to clinical, which is symptoms. Clinical is symptoms only. Endoscopy is where you visualize the lining by colonoscopy. That's a great question. You can't obviously see the full thickness of the wall. I didn't go into that because those are aspirational goals. We are not there yet as far as treatments and stuff. You have to have imaging by either a CT scan or MRI to actually determine healing of the entire wall. Because at endoscopy, you're only looking at the inside. You can't see what's on the outside of the wall. Ultrasound is something that's commonly in practice in Europe. It's not widely used here. The challenge with ultrasound is having the expertise. It's certainly useful, but we don't have the kind of expertise here to use ultrasound widely. And there are several centers which are starting to use ultrasound nowadays, and that might change in the future, but we are not there, at least in the United States.